This video will provide an overview of the background and rationale of the TRACK trial. The TRACK trial will evaluate whether a small dose of rivaroxaban, a blood-thinning medication, would reduce cardiovascular death or major cardiovascular events in patients with advanced stages of chronic kidney disease. Compared with people with normal kidney function, those with chronic kidney disease are at a greater risk of cardiovascular events and associated mortality. The risk of cardiovascular events increases linearly with worsening EGFR. A cardiac cause accounts for nearly 50% of all deaths in patients with CKD stage 4 and 5, and 60% of all deaths in patients with end-stage kidney disease needing dialysis. The coagulation system in advanced CKD is profoundly impaired, such that patients with CKD are not only at an increased risk of thrombosis, but also spontaneous bleeding. The risk of major bleeding increases linearly with worsening EGFR and albuminuria, and the bleeding risk in patients with end-stage kidney disease is much higher. This risk may be aggravated further with the incremental use of antithrombotic agents. Antithrombotic therapy is a core intervention in the prevention of cardiovascular events. Unfortunately, nearly 60% of trials evaluating antiplatelet agents and almost 90% of trials evaluating anticoagulant agents excluded patients with CKD. And no trial has evaluated these agents specifically in patients with advanced stages of CKD and end-stage kidney disease. As a result, there are no evidence-based guidelines on antiplatelet agents or anticoagulants for the prevention of cardiovascular events in this patient population. The KDIGO guidelines for these agents in CKD patients for the prevention of cardiovascular events is the Level 2B suggestion. Only an adequately powered trial can address the uncertainty regarding potential benefits and harms of antithrombotic agents in this patient population. In the COMPASS trial, more than 27,000 patients with coronary or peripheral artery disease and one additional cardiovascular risk were randomized to receive rivaroxaban 2.5 mg twice daily plus aspirin 100 mg once daily, rivaroxaban 5 mg twice daily, or aspirin 100 mg once daily. Although the trial included more than 6,000 patients with CKD, those with EGFR less than 15 mL per minute were excluded. The primary outcome was major adverse cardiovascular events, which was a composite of cardiovascular death, myocardial infarction, and stroke. The trial was stopped early when 50% of planned events had occurred due to overwhelming benefit with the rivaroxaban aspirin combination. Compared with the aspirin alone group, the risk of major adverse cardiovascular outcomes with the rivaroxaban was decreased by 24%. The low-dose rivaroxaban and aspirin combination also reduced the risks of cardiovascular death, all-cause death, ischemic stroke, venous thromboembolism, and in patients with peripheral artery disease, it reduced the risks of acute limb ischemia, major adverse limb events, including major amputations. Although the risk of the primary outcome in the rivaroxaban 5 mg twice daily group was lower than the aspirin alone group, it did not meet the statistical criteria pre-specified for the interim analysis. As expected, the risk of major bleeding was greater in the rivaroxaban aspirin group than the aspirin alone group. However, there was no significant difference in intracranial or fatal bleeding between these two groups. The subgroup analysis according to chronic kidney disease at baseline showed that there was no significant interaction of efficacy and bleeding outcomes by CKD status. Importantly, the net clinical benefit outcome, which was a composite of efficacy and bleeding outcomes, was also in favour of the rivaroxaban aspirin group. The relative risk reduction in major adverse cardiovascular events in CKD patients was similar to that in those without CKD. However, due to the greater event rates in CKD patients than those without CKD, CKD patients derived a greater absolute benefit. Based on these results, rivaroxaban 2.5 mg twice daily with aspirin is approved in patients with coronary and peripheral artery disease, including in CKD patients up to eGFR as low as 15 mL per minute. The dose of rivaroxaban in the COMPASS trial was 75% lower than that required for full anticoagulation. The observed beneficial effect of low-dose rivaroxaban in the COMPASS trial cannot be explained by its anticoagulant effect. Preclinical studies showed that rivaroxaban inhibits the signaling of protease-activated receptor 2 by inhibiting factor Xa. Rivaroxaban also inhibits the signaling of protease-activated receptors 1, 3, and 4 by inhibiting thrombin. These protease-activated receptors are critical for platelet activation and development of inflammation. These receptors are also involved in production of pro-inflammatory cytokines and endothelial adhesion molecules involved in atherothrombosis. In addition to the promising data from the COMPASS trial, pharmacokinetic and pharmacodynamic studies show that rivaroxaban has predictable properties. The kidneys eliminate 1/3 of the parent drug, and the remaining 2/3 is metabolized into an inactive form in the liver. The influence of kidney function on pharmacokinetics in people with creatinine clearance less than 30 mL per minute is considered to be only moderate. Pharmacokinetic studies have shown that the terminal elimination half-lives of rivaroxaban in dialysis and CKD stage 4 patients were similar to those seen in healthy subjects. The total daily dose of rivaroxaban in this trial is only half to 1/3 of that required for full anticoagulation in this patient population. These data suggest that low-dose rivaroxaban is a promising novel treatment option for patients with advanced chronic kidney disease, including those needing dialysis. The primary objective of the TRACK trial is to test the hypothesis that, compared with placebo, low-dose rivaroxaban, that is, 2.5 mg twice daily, significantly reduces the risk of major cardiovascular events in patients with advanced chronic kidney disease and an elevated cardiovascular risk.
Thank you for listening. For more information, visit the TRACK webpage at tracktrial.org. See the other guidance videos in this series, speak to your site's principal investigator, or email the TRACK team at tracktrial@georgeinstitute.org.au.